Education Subcommittee meeting. We have been conducting monthly sessions, webinars on interesting topics in infectious diseases, which we call it as ID Masterclass. And today's master of the ceremony would be Professor Arvind Raghukumar, who is Professor of Infectious Diseases at Government Medical College, Trivandrum. And Dr. Arvind, please take over.
Thank you, sir. So good evening. Today, the topic is interpreting clinical science, the forgotten art. You know, just like in any specialty, the core of ID is also about taking a history properly as well as eliciting the clinical science, which actually helps us in, framing the clinical syndrome. So without identifying or having an idea about the clinical syndrome, we cannot choose empirical antibiotics. Also for isolation purposes initially, we need to have a very good grasp of the clinical science. To shed light on this topic, we have an excellent speaker, Dr. Rajalakshmi. She is a senior consultant in ID and group lead HIC, KIMSL Trivandrum. She is trained in both internal medicine as well as infectious disease. She is a fellow from Apollo Hospitals, Chennai. She has done her observership in transplant ID in Wayne State University, Detroit. She is certified in infection prevention and hospital epidemiology. She is a fellow of Infectious Disease Society of America. She is also the brand ambassador for SHIA for 2022. She is an avid researcher with more than 40 publications. And on top of it, she is a very good painter. The reason why we chose her to shed light on the topic is the art of interpreting the clinical science. Over to you, madam.
Thank you, Arvind and the 6th PGCME committee. My first of all appreciation for this committee because for regularly conducting a monthly CME, which has actually attracted a lot of residents and with a lot of interactions and definitely a good input and feedback. So please keep it up. And I also enjoy these sessions. All these are basics in ID. So the topic that is given to me today is interpreting clinical science, the forgotten. So before I go forward, the disclosures and dictums, clinical science cannot be explained in 30 minutes. Let me first disclose that because it's a tough task. When Arvind asked to talk about this topic, I initially accepted, but when I started preparing this topic, I knew that I won't be able to finish and I may miss an important clue. So if I miss any of those important clinical science, please forgive me because it's because of the amount of time or anything that you want to know. And the references that I have done is not journal, as you know, just clinical science is basically Davidson, Mandel, and lessons that I learned from cases, my own and my colleagues, great big emphasis. The history is the most important tool. Though I'm going to talk about clinical science, I still feel that in ID, history is the most important. Though history may point to a single system, systematic examination is warranted many times, and it is a must. May need to review the clinical science for evolution. You may miss the first time, but then or during the course of illness, especially if the patient has symptoms, please revisit the clinical science to be examined. And certain signs may be seen in more than one disease. So it may not be pathognomonic, but it may give a clue. So if you put together the history, the clinical science, the post, and the diagnostics, you will definitely fix the diagnosis most of the time. So I will start with this Osler, William Osler's quote, like Osler said, listen to the patient, please tell him the diagnosis. It is not a phrase, it is actually a fact. And I definitely feel that at least once in your lifetime as a clinician, all of us would have missed a clinical diagnosis and then fix the diagnosis after getting an imaging or a diagnostic test. And then when you go back to the patient and see the clinical sign will be staring at you. So it's nothing like examining and finding a sign and then matching. So that is a systematic way. So how to go about this topic is the most difficult thing I found. So when I went to Davidson, I found this chart, this picture. So I thought I will go head to foot, and I may miss most of the organs, but important thing I will try to cover, and we can have a discussion. So I will start with a case of central nervous system, a young male with fever, headache, 2 days duration, followed by outputs and so on. You can put your thoughts in the chat box just to be interactive. I will not be stopping in between so that we can cover the cases. So your syndrome will be inactive encephalitis syndrome. But your differential that should go through in your mind is not only encephalitis, it could be viral or bacterial meningitis, it could be brain abscess, cerebritis, subdural edema, and sinus, either cerebral venous or sinus thrombosis. All this can present like this syndrome. And probably imaging may help you with the diagnosis. But the first and foremost will be acute encephalitis syndrome. So this patient develops segmental myoclonus in the legs, autonomic dysfunction, myocarditis, and stress problem, and goes on to develop ARDS and dies on wake-up. So any thoughts in your mind, you can put down the chat box so it will be more interactive. So on the next day, the PCR coronavirus came as positive in the CSF. So at this point in time, there was a cluster of cases happening in Calicut, and the possibility of a new viral syndrome was thought in the unusual clinical features, which is not found in this region previously, and these patients are rapidly deteriorating, and the clustering was noted. And it was also made later published as an editorial in the IGCCN by the initial cases. Later, in the clinical infectious disease, this got published, the clinical manifestation of the virus, who were later, the cases were admitted in the medical certificate. And what did they find in the first initial presentation was segmental myoclonus. Is segmental myoclonus described in NIPM? Yes, if you look at the Malaysia and Singapore, up to 50% cases had segmental myoclonus. And but strikingly, when you look at the Bangladesh outbreak, segmental myoclonus was not described, not any of the patients were MRI, and most of them presented with respiratory symptoms. So this is very classically described in the Malaysian Singapore outbreak, and these features were found in most of the cases that were found in the Calicut outbreak. So the message is, if you find encephalitis, segmental myoclonus, myocarditis, or stress cardiomyopathy with ARDS, suspect it. Why? Because the clubbing of all these clinical signs to form a syndrome should give a clue to NIPA. Why? Because the mortality is high, the CFR rate is in that cluster was 83.3%, and most importantly, community transmission was happening in 11 of the 12 cases documented community transmission. So you,
excuse me, madam, your voice is breaking a bit.
Okay, so I will remove the headphone and see. Is it okay now? Is it okay now?
It's better.
Hello?
Continue, madam. It's better now.
Better, okay. So the clinical clues to encephalitis may be different based on the structure of the brain that is involved. It can present a seizure or myoclonus, and commonly seen in HSV, West Nile, and JE. It can be in the frontotemporal and causing limbic encephalitis, where aphasia and personality changes may be the presentation, and it is commonly seen in HSV, HHV6. But you should also think of autoimmune and paraneoplastic if a patient presents with features of limbic encephalitis. What about basal ganglia involvement? JE and West Nile has a preference to basal ganglia. And brainstem features are classically seen in HSV, enterovirus, West Nile, and in case of listeria and melioidosis. The cranial nerve palsies are much more common in TB and fungal than viral etiology. Agitation, anxiety, hydrophobia, autonomic dysfunction, and features of SAIDH are commonly seen in furious rabies. Cerebralitis is classically seen in herpes group of infections, including EBV, HSV, zoster, and CMV. And it is also seen in rarely influenza and mycoplasma. Flaccid paralysis is commonly seen in West Nile, JE, enterovirus, paralytic rabies, polio, tick-borne, and post-infectious. So it is very, very difficult to remember all this. But if you can find that such a symptom and sign is there in the patient, and then clubbed with the other histories and the findings that the systemic findings that you have, probably you will get a clue towards a diagnosis, which you can later confirm. So general examination, what are the clues that you should look for are skin rashes, which can present many of the viral infections and some of the non-viral infections, including rickettsiosis. Oral ulcers will give a clue to Pangina, enterovirus, or HSV. Ocular findings may give a clue to CMV or West Nile. Parotitis, orchitis, and oophouritis may suggest mumps or lymphocytic proteomeningitis. So coming to the next organ that we commonly see, not in the OP, but as a referral, is those infections that is part of involvement is the eye involvement is part of the systemic syndrome or purely an eye and oropharyngeal involvement. So the pink eye as a sign of systemic illness, you may find a variety of illness and it is difficult to remember, but I'll just highlight a few because these are important and you have to consider because these are common as well. Viral conjunctivitis usually occurs as outbreak and common causes are Coxsackie in HSV. Pink eye with fever and URA, think about rubella, measles, mumps, influenza, and EBV, and look at the oral cavity for ulcers. Pink eye, fever, and rash, you think of dengue, Zika. In Zika especially, you will find itchy rash, and as you can see in the picture. And bacterial causes are many, which can cause pink eye. Commonly, it is chlamydia. There are several non-infectious causes as well for pink eye. So if you find poplic spots, these are small white spots surrounded by erythema, classical in measles, along with red eye and URA symptoms. This presence of poplic spots is very, very classical of measles. There are several other signs which you can look into the eye and find out. One is a subconjunctival hemorrhage and jaundice, which is very, very classical lepto, but it can be found in many of the cases of CLD who has a low platelet and they can bleed into the conjunctiva. Another important sign is subconjunctival petechiae, which is commonly seen in infective endocarditis. Endophthalmitis presents as eye pain, decreased vision, hypopyon, and this can be either exogenous, which following a trauma, or an endogenous due to bacteremia, and it can be caused by either bacteria or fungi, including Candida. Fundus is a large topic I'm not going to touch upon fundus examination or the features of fundus today. But what is another important clinical features or clinical syndrome that we find as a referral, or you may see in the OP, is uveitis. And this picture beautifully depicts that more than infectious causes, non-infectious causes are very common in uveitis, and infectious causes amount for most of the posterior uveitis, but rarely do you find an infection as a cause for anterior and other panuveitis. So if it is an anterior uveitis, the common organism is HSV, which is found in 90%. Other viruses like zoster and syphilis and TB can also be can also cause anterior uveitis. In posterior uveitis, the commonest cause is toxoplasma, and any of the herpes group of viruses can cause acute retinal necrosis, which includes zoster, HSV, and CMV. And you can find syphilis as a cause in some of the cases. Panuveitis is typically seen in syphilis, TB, or due to Candida. But remember, in tropical regions, leptospira, leprosy, and chikungunya can also cause uveitis, and brucella is a cause of chronic relapsing uveitis. Coming to the next common problem that we may see as an inpatient is preseptal cellulitis and orbital cellulitis. And these are considered as emergency because they present with red and swollen eye. And to differentiate between these two, preseptal cellulitis, usually the vision is normal because this is the area that is affected is anterior. There is no afferent pupillary defect. The movement of the eye is normal and it is a painless eye, no proptosis. Whereas in orbital cellulitis, what happens is there is ophthalmoplegia because the extraocular emulsions are involved and there is proptosis and they may present with eye pain. So when do you suspect cavernous sinus thrombophlebitis? As you can see in the previous picture, so if this eye is affected and this can spread through the cavernous sinus to the opposite eye can also get affected. And in such cases, what you find is bilateral neuropathy. So if an orbital cellulitis presents and in 24 hours contralateral signs are seen and you suspect cavernous sinus thrombosis and the spread occurs through the cavernous sinus, and all these cranial nerves, that is 3, 4, and 6 are very adjacent or close to the cavernous sinus, and these are the common nerves that are commonly involved. And the organism that can cause this is Staph aureus, strep anginosus, anaerobes, and GNV. Other cranial nerves can also get involved, as I have shown here, the fifth nerve, and it is affected in 28% of the cases. And if this nerve is affected, if sphenoid or ethmoid sinusitis is involved, and the classical sign is absence of sensation of the forehead and cheek. Sometimes you can have a cavernous sinus thrombophlebitis without orbital cellulitis, in which case the danger area of the face is affected, or it's the dental infection, which is the source. Subacute presentations are very rare and can be caused by actinomyces group of infection, and is often misdiagnosed as Tolosa-Hunt syndrome, which is a non-infectious inflammatory syndrome, and such patients may end up receiving steroid initially. So this is very easy. I think many can start voting for the diagnosis. Yeah, it is HZO, that is herpes zoster ophthalmicus and oticus. The oticus is otherwise called as Ramsay-Hunt syndrome. So herpes zoster ophthalmicus, if it affects the first and second branch of the trigeminal nerve, it can cause the lesions over the nose and the forehead and the eye. And the most important or worrisome thing is the keratitis and loss of vision. If the second and third, that is maxillary and mandibular branch of the trigeminal nerve is affected, then you have oral involvement, as I have shown there. One half the tongue has vesicles as well, and they can have vesicles over the palate, tonsillar fossa, and the floor of the mouth. If the facial nerve geniculate ganglion is affected, and where you have pain and vesicles in the external auditory canal, as well as the loss of taste in the anterior 2/3 of the tongue and the ipsilateral facial palsy, and this syndrome became more popular when Justin Bieber got affected by this. Any of you can try to find this syndrome. It's it's not common, but this case is very common in our outpatient as well. A patient presenting with severe pharyngitis, tonsillar exudate, and palatal petechiae, and has a rash with non-tender generalized adenopathy and splenomegaly. And what you find is a periorbital edema. This sign is called Hogland sign, and is commonly seen in IMN, and it's actually a pathognomic sign that is described. And if you find a feature of a pharyngitis with skin rash and adenopathy with this periorbital edema, you should highly think about IMN as a diagnosis, and this edema is called the Hogland sign. Such patient may also develop diffuse maculopapular rash with ampicillin or related compounds, and this IMN as such is called mononucleosis-like illness, and it can be a presentation of any other infection like CMV, HHV6, HSV1, HIV, and toxoplasma. In HIV, if you may not diagnose HIV at this point of time by doing a serology, and you have to do P25 antigen or HIV RNA to diagnose at this early part of the illness. I will spend a few minutes on acute pharyngitis because it's the commonest problem that we find in the outpatient, and it's the commonest problem where antibiotic use is highest. So this 16-year-old presents with fever, sore throat, congested pharynx, tender cervical lymph nodes. Will you treat with antibiotic? Is it viral or bacterial? So what is suggested is to follow the Centaur score. Hope most of you would know. Otherwise, you can go through. This is published early in 2004 in JAMA. The score is given for each of the symptoms, and points are calculated. And age also has given a point. And if you have a total score of more than or equal to 4, you make a diagnosis of a streptococcal infection causing pharyngitis, and you'll be correct in more than 50%. And what is advised is you can empirically treat with antibiotic. There are difference of opinion between the two bodies, that is IDSA and AAP. They recommend culture confirmation for gas or RADT before you proceed with treatment. But CDC and ASP suggest empirical treatment based on a pharyngitis score alone without microbiologic confirmation. So Why are you more worried about the gas, this group A strep causing pharyngitis? It can lead to rheumatic fever, and center score is more useful to rule out gas. So if you have a negative score or 0 or 1 score, you can straight away think about a viral cause and keep a follow-up, or you can proceed with rapid strep test if you have a borderline score. So with all these features, still the positive strep culture from the throat is only 57%, and sometimes patient may be exposed to antibiotics. Scarlet fever is usually seen in children. It's again related to group A strep pharyngitis, and this rash is due to the exotoxin, and it is a sandpaper-like quality. So this is usually commonly seen in children. But what is the commonest cause of pharyngitis is viral pharyngitis, and this is classically presented with oral ulcer. So if you find oral ulcer, it gives an important clue that it is a viral pharyngitis. So if you find oropharyngeal ulcers, gingivostomatitis with or without odonophagia, which may suggest esophagitis in an young adult, please think of HSV as well. It may be the first episode of HSV, and unless you know go to the history of their sexual habits and so on, you may miss the diagnosis. Small vesicles of the pharynx in children, it is usually herpangina due to enterovirus, and majority are caused by Coxsackie. If you have, along with viral pharyngitis, a red eye, then the commonest etiology is adenovirus, and it can happen in outbreaks, and it is associated with using swimming pools. If you find these oral pharyngeal ulcers with pharyngitis and small vesicles on the hands and feet and buttocks, then it is suggestive of a hand-foot-mouth disease, again caused by enterovirus and majority of Coxsackie. So these are important clues for viral pharyngitis, and if you have another organ involvement, you can actually make a very good diagnosis by looking at these clinical clues. So also remember that some of the systemic virus can also present as viral pharyngitis, like EBV and CMV, where you will have generalized lymph nodes or rash along with pharyngitis, or you may have it may be due to respiratory viruses, commonly due to influenza or parainfluenza or metapneumoviruses. So to reiterate, those suggestive viral etiology, the important signs are conjunctivitis, coryza, cough, diarrhea, and oral ulcers. Just like center score, that is, you can use as a predictive rule for diagnosing group A strep. For this viral, you can use these findings, and if one or more such findings may favor viral, and you can very well withhold antibiotics and give a follow-up. And I also wanted to make that you should remember still that there are cases of pharyngitis with membrane. It can be commonly due to many causes, including strep, but you have to remember that there is a condition still that we are facing, that is due to Corynebacterium diphtheria, where these membranes are totally, it looks totally a little different in that it is dark gray and leather-like, and attempt to dislodge such membrane may cause bleeding, and if there's a large press, the patient can have progressed to have large nodes in the neck, and they can present as bull neck. And this membrane formation is a result of local toxin, and the nodes are reactive. So if the large nodes, they can progress to respiratory distress and even death. Also remember, there is a group of young people presenting with pharyngitis. You have to keep gonococcal pharyngitis as a BD, and just like HSV, but there won't be any oral ulcers, and it is a milder form of group A strep. That is what the clinical picture is. So unless you ask for other history, you may easily miss this diagnosis. Atypical bacteria are a rare cause of pharyngitis, and in such cases, azithromycin may have a role, but we rarely diagnose, nor do we focus our treatment on that. Coming to the next interesting syndrome that each one of us in our ID would have seen, and this is a Lemierre syndrome, which is caused by Fusobacterium necrophorum, and it is an oral anaerobe. It mimics group A strep, just like it presents pharyngitis, and initially there may be some improvement, but later on the patient presents with rigor, peritonsillar abscess, jugular thrombophlebitis, and septic pulmonary emboli, and also embolic to the distant organs like spleen. They may have respiratory distress as well. On clinical examination, if a patient who has pharyngitis also have tenderness and swelling in the neck, as well as induration along the jugular vein or the stenochleidomastoid, you have to think about Lemierre's and do appropriate imaging and actually decide on the antibiotic choice, because you have to give an anaerobe, oral anaerobe cover. The choices would be amoxiclav or ampicillin sulbactam. Moving on to the lung, it's a big topic by itself, but I think I will touch upon only this acute interstitial pneumonia caused by this organism. By looking at these pictures, I think it is an easy clue to the organism that I'm going to talk about in this slide, that is Mycoplasma. Mycoplasma is one organism which can present in so many extra pulmonary manifestation, systemic manifestation, and the pneumonia can be very, it may not be very visible, and the patient may not be having a prominent respiratory symptoms. So they may initially even present with these extrapulmonary symptoms. So you have to be very careful and maybe do an imaging to diagnose sometimes, because they may not have a classical signs and symptoms of pneumonia initially. So they can affect, this manifestation can affect any organs from skin, lungs, heart, central nervous system. They can present as encephalitis. They can present as rhabdomyolysis, arthritis. They can present as Raynaud's, glomerulonephritis, and they can have a lot of hematologic involvement in the form of hemolysis, etc. So these are produced by, these symptoms are produced mainly by the IgM antibodies, which are cold agglutinin. And remember, these antibodies are first seen in the first initial week of the clinical illness, where when the pneumonia may not be that evident. So later on, you may find a pneumonia and you may diagnose all this after putting all together. So Raynaud's and hemolysis may be the initial presentation also. Going on to another system, this is a case by Dr. who was recently seen by Dr. Nias, and thanks to him for sharing this case. So this case is an interesting case, and it is a clinical diagnosis. So anyone can try this. So this patient presents a month ago with this small pustule which was drained. It is, as you can see, it is on the thumb. He has underlying chronic liver disease. And a month later, he presented with a stroke. And at that point in time, another abscess was noted in the middle finger. So he is a patient with chronic liver disease. He presented with low-grade fever and digital abscess. And this abscess first was drained and it grew E. faecalis, and he was treated with cephalosporin sulbactam clindamycin, which is not the drug of choice for that organism. And 2 weeks later, he presents with embolic stroke. At this point in time, another pulp abscess was noted in the middle finger, and at this point in time, blood grew E. faecalis. He was also noted to have hematuria and proteinuria, an acute kidney injury, and a suspected glomerulonephritis. So, and on auscultation, he has an early diastolic murmur in the left sternal border. So, what you find is telltale signs of IE, and he does not need an echo to fulfill the IE criteria, though he may need an echo to confirm the diagnosis, to rule out complications and plan surgery. So if you look at the Duke's criteria, which is the criteria that is used for infective endocarditis, for definitive infective endocarditis, you need a clinical criteria, which is 2 major or 1 major and 3 minor. And if you look at this patient, he had enterococcal bacteremia, which is community acquired. Yes, he fulfills 1 major criteria. He also has a early diastolic murmur, which is probably a new onset. He has minor criteria, which is fever, major arterial emboli in the form of stroke. He has Janeway lesions, which you see in the hand, and he has glomerulonephritis. So he is a confirmed case, or a clinical criteria. He is not a possible, it is a confirmed case of IE. And later on, it will show vegetation, aortic valve, and there are several other features, peripheral signs that you can find in IE. Unless you look for, you may miss all this. These are petechiae, which is commonly seen in the conjunctiva. Rot spots are seen in the fundus. As you can see, these are oval, pale, and retinal lesions, which is surrounded by hemorrhage. And it is not only found in IE, it can be seen in severe anemia, leukemia, and SLE. So it is not pathognomic of IE. Just few differences between ocellular nodes and Janeway lesions. Ocellular nodes are small, painful nodular lesions, and these are commonly seen in pads of fingers and toes. And these are evanescent and disappears in hours to days, whereas Janeway lesions are hemorrhagic, painless macules seen in palms and soles and persist for several days. So the ocellular node are usually seen in subacute, not in acute case of IU. So it presents in subacute forms, but this embolic phenomena can occur anytime, and it also depends on the size of the vegetations, and more commonly seen in Staph aureus. So as I said, this is an immune-mediated pathology, the oscillatory node. So it can be seen in other conditions like SLE, marantic endocarditis, hemolytic anemia, and gonococcal infections as well. Whereas this is classically seen in IE with septic emboli and commonly due to staph eye. But other than murmur, all other features, that is peripheral signs of endocarditis, are seen less than 25%. So unless you carefully look for, you may miss it. And this is on searching 2,700 patients with IE, definite IE, they found that these signs are less common to the tune of 5% to 26%. Coming to a similar picture, but a different etiology. If you look at this patient presents with low-grade fever, arthritis, and skin lesions. And these skin lesions are hemorrhagic, necrotic papule, and also noted to have acral petechiae. So it is, what is this syndrome? It is an arthritis dermatitis syndrome. We also noted to have multiple pustules. And on his taking history, there was history of urethral discharge. A punch biopsy of the lower leg is confirmed, blood cultures were sent, urethral culture was also sent, and in such culture, we also sent for a combined gonococcal chlamydia probe for nucleic acid test or the STD panel and a syphilis screening. And in this patient, the urethral culture, gram stain show gram-negative cocci, and later it was confirmed case of disseminated gonococcemia. So any arthritis dermatitis syndrome with a history of urethral discharge, the confirmation, the syndrome actually is a classical sign, and it is noted in 86% of disseminated gonococcemia. And the triad include cutaneous lesions, tenosynovitis, and joint disease. And joint disease can be migratory, asymmetric polyarthralgia, or oligoarthritis presenting as septic arthritis. So you have to keep this as a differential for all the monoarticular septic arthritis. Cutaneous lesions can be very, very variable, and most common are papular pustular lesions. Cultures should be obtained for all the mucosal surveys, including cervix, pharynx, rectum, and urethra, to improve your diagnostic yield. And the differential for such syndrome would be endocarditis with septic embolization, which you saw in the previous case, Rocky Mountain spotted fever, secondary syphilis, and there is one entity called chronic meningococcemia, which is very rare, and several other non-infective causes. So coming to the more classic presentation of this syndrome, I think you can all try to guess what is this picture. Yes, it is meningococcemia. So meningococcemia is called the story of Dr. Jekyll and Mr. Hyde, because like Dr. Jekyll, there's a common commensal in the nasopharynx quietly lying there. But if it is an invasive, it can behave like Mr. Hyde, that is, it can cause purpuric rash, purpura fulminans, necrosis, and gangrene. And in very severe cases, it can cause DIC and bleed into the adrenal glands, causing Waterhouse-Friderichsen syndrome. And this is due to rapidly increasing bacteremia, and the endotoxin that is associated with this is the endotoxin called as LOS. That is the protein. In such cases, the protein C and complement deficiency. Also, there is a deficiency, and such patients tend to have a very severe disease. But this patient was lucky. It was a confirmed case of meningococcemia, but then he underwent aggressive therapy, but he ended up losing his limbs, and then later replaced with prosthesis. The nose was reconstructed, and now he plays football. This is again a similar picture, but a different diagnosis. As you can see, this is classical, called as livedo reticularis-like picture. And this patient also has gangrene or ischemia involving the earlobe, the legs. And this was reported as related to Rocky Mountain spotted fever, and was published a few years ago. It was in our hospital by Dr. Anu, Dr. Matthew Thomas, Dr. Herschel, and they found that there's a clustering of these cases. They present with vasculitis, gangrene, and it's an uncommon complication of Rocky Mountain spotted fever. all these patients had severe sepsis and multi-organ dysfunction and were diagnosed by using immunofluorescence assay. And they noted that there is a 4-fold raise in the IgM titer, and they presumably this was caused by Rickettsia canoris species indica. Another much similar syndrome, but a different presentation is this male who presents with 1.5 months of diarrhea, intermittent fever, light loin pain and weight loss. And he also noted to have rashes, which is purplish and which was initially thought to be vasculitis. And he ended up developing hypoxia and noted to have eosinophilia. So because of the hypoxia, he underwent initially X-ray and then the CT, which shows interstitial pneumonitis. So what is this syndrome? This is very classical and it is known as Leofler syndrome. There are several etiologies for causing this syndrome. And that is grouped under pulmonary infiltrates with eosinophilia called the PI syndrome. And this patient has this pulmonary eosinophilia, infiltrates with eosinophilia. And in addition, he also has chronic diarrhea and rash. And what could be the possible etiology? His stool, he underwent, because of the chronic diarrhea, he underwent stool examination, which is shown here, as well as he underwent duodenal biopsy. Both stool and duodenal biopsy revealed strongyloids. Blood culture grew Klebsiella, and he also noted further developed meningitis, and CSF culture grew ephesia. So remember, the strongyloids, the larvae, when it migrates, it penetrates the intestine. And there is a bacterial gut translocation happening constantly in such hyperinfection. And this can cause bacteremia, spontaneous bacteremia, just like in SBP, in CLD patients, and it can also result in meningitis. So this was a case of strongyloids hyperinfection, which was later published. Coming to other infection, that is skin and soft tissue infection, which is again, is an important infection for all ID physician and the physicians. And this patient presents after minor trauma, presents with cellulitis. As you can see, he has erysipelas-like lesion with generalized erythema over the adjacent area. This is another case who presents with post-venectomy cellulitis in the leg. So this patient, the first case who presents with minor trauma and cellulitis, 12 hours later, there is hypotension, multi-organ dysfunction, and underwent fasciotomy for necrotizing fasciitis. And the gram stain of the tissue fluid is shown here. As you can see, it shows GPC in chains, and the fluid and blood group strep pyogenes. So this is classically a toxic shock syndrome because this patient also has hypotension. The drug of choice is penicillin. Clindamycin is added to reduce the toxin. IVIG has a role in strep-related toxic shock syndrome. So this is the toxic shock syndrome definition. And if you have a blood or any other site which is involved growing a strep pyogenes, in addition to the patient should have clear hypotension and 2 or more of the following findings like renal impairment, thrombocytopenia, liver involvement, and a generalized erythematous rash and necrotizing fasciitis. So any 2 of these features, in addition, patient should have hypotension and strep pyogenes grow. So this patient that we have discussed in the previous cases fulfills many of the findings and is a classical case of toxic shock syndrome. So toxic shock syndrome can start as erysipelas as shown here. They go on to develop cellulitis and deeper regions of the skin is involved and can result in necrotizing fasciitis. And many times they need debridement, a source control to reduce the progression and to as a source control. This is another case of serious skin and soft tissue infection. A 62-year-old male presenting a severe pain in the left gluteal region and upper part of the thigh since morning. There was no trauma, backache, or undue exertion. So initially, he was seen in the emergency, and he was given some analgesics. The pain doesn't improve, and he then proceeded for imaging. And 3 hours later, because of excruciating pain, a re-examination was done, which shows edema, brawny induration, purplish discoloration, and even crepitus. So this is a classical sign of bedside debridement was done, and patient developed refractory shock and death. And this is classically a case of a gas gangrene. As you can see, the brawny induration, the swelling, the purplish discoloration, all is suggestive with a crepitus, all suggestive of a very rapidly progressing myonecrosis, classically seen in gas gangrene. Later on, this blood culture group Clostridium septicum, and it is later confirmed in Maldi. So this is a case of Clostridium myonecrosis, which is spontaneous onset because there was no history of trauma, and it is due to Clostridium septicum, and it differs from perforations, which is usually followed after trauma. So septicum occurs spontaneously. It is hematogenous seeding from GI tract in a known or undiagnosed adenocarcinoma of colon. This is a very good chart which is published in IDSA guideline. So for a management of SSDA, if anyone can apply this, it is easy to follow and even diagnose. So the last two cases that we discussed belong to this non-purulent cellulitis, which started as erysipelas and then progressed to cellulitis and NF. So it belongs to severe category. And such patients, what is the first line is surgical debridement, which is the most important thing to do. And then empiric therapy, which should include piperacillin, tazobactam with vancomycin, and then follow up with culture. Historical clues to specific diagnosis will include, it could be a trauma, it could be exposure to seawater, it can be exposure to river water, and then it can sometimes be polymicrobial, especially in diabetic individuals. So some other case scenarios which actually are immune mediated, which we should keep in mind is case one is a tender indurated cord-like nodules, which is seen on the thigh, and the skin biopsy showed polyarteritis nodosa. And the second case is a palpable purpura, which again biopsy proved that it is cryoglobulinemia related, and there were immune fixation, direct immunofluorescence revealed complements and antibodies. So both these were clear-cut case of chronic hepatitis B. Later on, their antibodies were positive, and these features are suggestive of a deposition of immune complex causing cryoglobulins on the endothelial surfaces. If you look at, there are several other extra hepatic manifestations of hepatitis B. The commonest being telangiectasia, mixed cryoglobulinemia, and polyarteritis nodosa, which happens in up to 35% as per this literature, and most of them are responsive to hepatitis B treatment. This is another clinical scenario where you may find in your ICU. This is a 65-year-old male lady, recent stroke, received aspirin, losartan, beta-lactam, and 2 days later developed a diffuse rash, which is erythematous, which is dusky, and there are a lot of eroded surface. These are ruptured bullae with this formation. And most important, the oral and vaginal mucosa is not involved. Conjunctiva is also spared. When you examine this patient, palpate this patient, the top layers of skin slip away easily when rubbed. And this is classically known as Mikulski sign. So the patient underwent a biopsy to clink the diagnosis, and it showed subcorneal splitting, pharyngeal swab through MSSA, and it was diagnosed as a case of Skaldelsman syndrome. And the closest differential diagnosis where you find Mikulski is TEN. But this age is not classical. An adult is not a classical case for staph Skaldelsman syndrome, and it usually affects children, and they do well if appropriately managed. So the other name for Skaldelsman syndrome is Ritter, and the TEN is called the Lyle syndrome. So what is the difference? In both, they can have fever and malaise, and they can have Mikulski sign, but the Ritter involves usually neonates, but TEN can affect any age, and it is infection preceding in Ritter, whereas the culprit drug in TEN, and the mucous membrane are not usually affected in Skaldelsman syndrome, whereas in TEN, classically, the mucous membrane will also be involved. And all these scars heals without scar, but in TEN, it is a little more deeper, and there is a scar formation tendency. And the treatment for Skaldelsman syndrome is antibiotics for staph aureus usually, and for TEN, it is to stop the culprit drug and supportive care. Okay, so coming to another scenario, umbilicated papules, what should come your kind? The first thing is to rule out HIV, because this is a closed ED that is happening. 3 important differential diagnoses that should come when you find umbilicated papules, especially it is generalized and more often seen in the face. These are molluscum contagiosum, cryptococoma, and tuberomycosis, and these are commonly seen in HIV population. This patient had a low CD4 and a high viral load, and he also underwent serum crack test, which was positive, confirming that it is cryptococoma. So the next thing that we should do is to rule out cryptococcal meningitis. So he underwent CSF, which was negative for cryptococcal meningitis. A culture and crack was negative, and CSF cell count was normal, sugar and protein was normal. So this is a case of cryptococcemia and presenting as cutaneous cryptococoma, and he underwent treatment and improved well. This is another interesting case, but a different site. Presentation is at a different site. This is a necrotic lesion associated with fever, and she comes from a rural background. So initial diagnosis was vasculitis, like any of the granulomatous lesion that is affecting the central part of the face. Can be due to infection. The common infection of Staphylococcus, Pseudomonas, anthrax, and fungal. But this patient also had thrombocytopenia. He ended up in bone marrow, and she was diagnosed to have AML. The culture from the necrotic tissue group, Pseudomonas. Now you have the syndrome and the clinical diagnosis, and it's classically ecthyma gangrenosum. This is not the usual site. It is usually the extremity, but it's a rare site of ecthyma gangrenosum affecting the nose, presenting as a necrotic lesion. Last few slides, I will end the session with addressing the tropical infections and the classical signs. So a right foot swelling, this patient presents with right foot swelling, redness and paresthesia and numbness of 3 months. Swelling of left foot patch, numbness of 2 months. Swelling on the right hand, erythema and numbness extending below the elbow on the medial aspect of 1.5 months. So what is this syndrome? This is a syndrome of mononeuritis multiplex. So once you make a syndrome of this, you should have a differential diagnosis. I know that currently one of the commonest causes diabetes, but still in India, you have to keep another important differential diagnosis. This patient also had this erythematous lesion with raised borders, reduced sensation, and also had thickened, palpable, ulnar and lateral peroneal nerves. A nerve conduction study was done, which showed mononeuritis multiplex picture. Biopsy was done of the nerve, and it shows perivascular granuloma, epithelioid histiocytes. AFB was positive, nerve was surrounded by inflammation, granuloma, and was confirmed case of Manson's disease. And what is the reaction that he has present? He was presented with a reversal reaction. It was identified as type 1 reaction based on the features that he had. He didn't have fever. In type 2 reaction, the systemic features are more and the presentation is a little different. He had reversal reaction, increased erythema, warmth, and edema, and sometimes it can present with ulceration of the lesion, as well as increase in swelling and tenderness of the peripheral nerves. So the final diagnosis was borderline leprosy with type 1 reaction. Again, this is a classical sign called the chick sign or the brawny nose post-chikungunya. Scaly macular hyperpigmentation, where the tip and the bridge and ala of the nose are affected, and it is usually seen in the centrofacial part. There is no mucosal involvement in such cases, and this is called a post-inflammatory hyperpigmentation, and it causes for months. This Fain's criteria, again, you should know what is Fain's criteria, which is applied for leptospirosis diagnosis. This not only includes the clinical criteria that is described here, like fever, headache, myalgia, and conjunctival suffusion. And the points are given for all this, but it also includes other criteria which I am not discussing here. It includes exposure risk as well as the lab test. And with applying this, your probability of diagnosing leptospira or ruling out is high. And last but not the least, who would not have missed an scar in their life. So please remember, these are found in the moist and covered areas, axilla, inframammary region, and the groin. So unless you examine, you may miss the sign very well. So there are a lot of other signs which I will not be discussing because of want of time, but anyone can take this question that I have posted here. It is not the real quiz time which you are going to get now. Then you can try all these questions and you can put in the chat box. Tripod position is usually seen in epiglottitis. Hamann sign usually seen in mediastinum, where you get a crunchy sign. Murphy's sign is classically seen in biliary infections, cholecystitis. Charcot striae is seen in cholangitis, where jaundice, fever, and chills are common as striae. Raynaud's pattern is if cholangitis patient develops hypotension and shock. It is very specific for cholangitis. Fitz-Curtis syndrome is seen in gonococcal infection presenting as abdominal pain, right upper quadrant pain, and classical of perihepatitis, and the Dowby abdomen, classical of TB peritonitis. So there are several other syndromes and signs. And I think I have not done justice to the topic, but there are plenty to discuss as well. But due to time constraints, I will end this talk by this one more oscillatorism, that is, who studies medicine without books, sails, and uncharted sea, but who studies medicine without patient does not go to sea at all. But the best of his quote is, medicine is learned by bedside and not in classroom. Let not your conception of disease come from words heard in the lecture room or read from the book. See and then reason and compare and control, but see first. With that, I will stop this discussion and we can be open for discussion. Thank you so much.
Thank you very much, madam, for the excellent lecture. Actually, it was so wonderful just, taking us, you portrayed the entire beauty of clinical medicine in a limited span of time. And all the participants were eagerly, posting on the chat box when you were displaying all those wonderful cases and all. But I could not find any questions on the chat. If any of you want to ask directly, you can do so, unmute and do so. Everyone is just posting there. Thank you, madam, excellent, madam, etc. Okay. Thank you very much, madam, for the excellent lecture. Do you want to add anything more, madam?
No, I think there are many things that is uncovered. I know that, but then due to time constraints, I have to restrict, sorry. But I think actually getting all these cases pictures is, it's more rewarding, and to share these pictures and actually discuss cases based on these images is actually very nice than going on as a journal discussion. So totally a new topic that is given to me. Thank you so much. I enjoyed as much as preparing as much as others did.
Thank you very much, madam. Okay. So I think we will go directly to the photo quiz session. And
before you move, just a small announcement that please click on the link in the chat box. It is for a survey on how you feel that the SITS PG subcommittee ID Masterclass is going. I request all of you to please click on the link and complete the survey. Just take a few seconds. Sorry, Dr. Please go ahead.
No issue, no issue. You can also make the housekeeping announcement regarding how to answer the questions, whether they should answer it together.
So we will have 3 questions, right, Dr.?
Yeah, 3 questions. Each question will be having 3 parts.
3 parts. So we will look into the winners, and we will be you will be asked to type the questions in the answers in the chat box. Please make sure that you answer answer them together. Do not answer them after the first question is finished. Just make sure that all the 3 questions are answered at a stretch at the same time. The person who is answering them first will be announced, and we will give away the prize.
Hello. Hello. Am I audible?
Yeah, you are audible.
Ma'am, regarding the first case of Nipah virus, I don't think that triad or quadrant you explained can be make a specific for Nipah virus. Other viral encephalitis syndrome can also present with same findings, pertaining that Nipah virus is a very rare syndrome outside Kerala.
Yeah, I agree. See, encephalitis, segmental myoclonus, you can definitely think as so many etiology. But if it presents with autonomic surge and myocarditis and ARDS, please keep Nipah as a differential because of high attack rate, high mortality. That's what I would like to comment. Segmental myoclonus was not seen in the Bangladesh series. So I'm not telling that. But if you put these 3 things, what are the other differential diagnoses that you would get? Most of the encephalitis presents as a single organ involvement, and rarely they present with an autonomic surge. Only few hardly rabies-like syndrome presents with autonomic dysfunction, SADH, and several other involvement. But with this syndrome of segmental myoclonus with a autonomic surge, I think you should keep NIPA as an important differential diagnosis. We may be missing some cases. NIPA may not be rare, and it may be spreading because it's a zoonotic disease. So it should be a differential. Do you have anything to add on?
Can others please mute their audio?
Dr. Arvind, are you there?
Yeah, I also got muted. Okay.
Okay. So can we move to the quiz session? So,
yeah, definitely. My video is also, the host has stopped my video also. Okay.
I'm also trying to unmute, sir. Like, I didn't know.
Sure. Can you enable screen sharing?
You're able to share your screen, sir?
You should be able to share your screen now.
Yeah, now I can.
Yes.
Okay. So we will straight away go to the quiz part. So this was the question in the flyer. So a 45-year-old fisherman rescued from sea during Cyclone Oki presented in shock with history of high-grade fever, vomiting, excruciating pain and swelling of both legs of 2 days duration. He had been stranded at sea for 4 days and had sustained multiple abrasions on both legs. On examination, both lower limbs were swollen, tender with multiple hemorrhagic bullae, as you can see in both the pictures. And you can also see on the side of the board, some organism is attached. So the first question is, what is the causative organism? The second question is, what is the probable source of infection? Third question is, the same clinical picture, if the patient is presenting with the same clinical picture following exposure to brackish water, what is the likely causative organism? So I will read the questions once again. What is the causative organism? Second one is, what is the probable source of infection? Third is, the same clinical picture following exposure to brackish water, what is the likely causative organism? I will go to the next question. If you have listened carefully to Madam's talk, it will be pretty easy. A 15-year-old boy presented with fever and sore throat of 5 days duration. On examination, bilateral, painless upper lid edema without conjunctival congestion was noted, along with tonsillitis. Investigation showed mild transaminitis. So you look at the picture, you can see the bilateral upper lid edema. And if you're looking at the tonsils, you can see the membrane. This membrane is tonsillitis. So the question is, what is the probable diagnosis? That's the first part of the question. Second is, which test is used to diagnose this condition in the first week of illness? The third one is, name the clinical sign, that is bilateral painless upper lid edema without conjunctival congestion. What is the name of the clinical sign? So first one is, what is the probable diagnosis? Second is, which test is used to diagnose this condition in the first week? Third is, name the clinical sign, which is the bilateral painless upper lid edema without conjunctival congestion. I'll move to the last question. A 50-year-old man with history of recent international travel presented with fever, headache, cough, and rash. Now look carefully at the morphology of the rash. Okay, the clue lies in the morphology of the rash. You can also see the enlarged view of the rash. Now, the question is, what is the diagnosis? That's question number 1. Second is, what is the drug of choice? Third question is, name the vaccine which can be used for post-exposure prophylaxis for close contacts who are unimmune. First question is, what is the diagnosis? Second is, what is the drug of choice? Third is, name the vaccine which can be used for post-exposure prophylaxis. So that is the end of the quiz, and all of you can submit the answers. Dr. Nitin, just say when I should say the answers, when they are finished submitting. Okay.
So we will wait for 10 seconds.
Sure. Thank you.
Yes, Dr. Arvind, I think you can reveal the answers.
So the first case actually is a real life case. The answer is Vibrio vulnificus. Now during Cyclone Oki, this fishermen got stranded in the sea. So in order to prevent them from being taken away by the monstrous waves, they tied themselves to the side of the boat. The side of the boat will be having the crustacean. This is the barnacle. So barnacle will have high concentration of Vibrio vulnificus. And since they are tied to the side of the boat, both the legs had so many abrasions, and this organism entered through the abrasions and led to this necrotizing fasciitis. So the answer is Vibrio vulnificus. Source of infection is from the mollusk or the barnacles. And third one is, even though Vibrio vulnificus also can grow in brackish water, the same clinical picture can occur in Aeromonas hydrophila also, if the exposure is to brackish water. Now going to question 2, the probable diagnosis is Epstein-Barr virus related infectious mononucleosis. Test in the first week is going to be Epstein-Barr virus PCR. And the clinical sign, as Madam has clearly explained, is the Hoagland sign. And importance of this sign is that 10% of cases of IMN, you can see this sign if you look very carefully. It is very transient. It usually occurs prior to the onset of membranous tonsillitis. In this case, you can see the membranous tonsillitis, which is described in IMN as well. Usually, one of the features which helps us in differentiating diphtheria from IMN is the presence of transaminitis. Usually in diphtheria, the transaminitis won't be there. And third question, the clue lies in the morphology. So the answer is actually chickenpox, varicella zoster, because you are seeing the pleomorphic lesions. You are seeing the macular lesions, the papillar lesions, the vesicular lesions, as well as the crusted lesions in the same image. Usually in monkeypox, all the lesions will evolve together. So you will have the macular lesions, and all of them will progress to the papules at the same time, will progress to vesicles at the same time, pustules at the same time, and will crust at the same time also. So this is chicken pox, drug of choice, acyclovir or variacyclovir, and the vaccine which can be used for post-exposure prophylaxis is actually varicella zoster vaccine. So that is it.
So I think, Dr. Arvind, nobody has answered all the 9 questions correctly. So I can't say that we don't have a clear-cut winner, but I will choose the first 2 who has answered maximum right. So
Sure.
first one is Dr. Vishal Gupta. He's the one who has answered most of them right, except for saying VZV PCR. He has written monospot test and he's written saline water. I think that we can take that.
Okay,
Other
then we
one
can
is
take.
Dr. Rahul Garg.
Okay.
Vishal Gupta and Rahul. These are the 2 winners.
Congratulations to the winners. Did anyone give the answer as monkeypox for the last one?
Lot of happy with monkeypox.
Okay, that is actually the take-home message. Okay, so you should not be misled by an international traveler. You should clinical examination means that you should look at the patient very carefully, examine the morphology of the rash, etc. Okay.
So I request winners to please type their mail IDs in the mailbox before we close this session, and also click on the link to do the survey. Dr. Vishal and Dr. Rahul Garg. I think we can close this session, Dr.
Sure.
Ambisa is there? Or you?
Nitin, you can close it. Then.
Okay. So I think I'll thank everyone. I also request before we close the session just to click on the link so that you can complete the survey, and we will get your feedback and probably make ourselves much better than what we are going through. And I thank you all. We will soon message you regarding the next webinar and see you there. Thank you, Dr. Arvind, for the for taking the webinar, and Dr. Raji Lakshmi Madam for taking the beautiful lectures which she did. Thank you.
Thank you.
Good show. Bye.
Thank you, ma'am. Thank you.
Yeah.